Welcome to our April MPRINT Hub webinar. Today's talk will be on bioethical issues in maternal and pediatric research. I'm Sarah Quinney. I'm the PI for the MPRINT Hub Knowledge Research Coordination Center at Indiana University, and I'll be hosting today's webinar. Before we get started with the webinar, I do want to mention a couple of things that may be of interest to our attendees and those who are watching this online. First is that we will have our MPRINT Hub annual meeting coming up June 13th and 14th. This will be a virtual meeting, and we will have availability on Zoom for you to register in the upcoming weeks. So keep an eye open on our social media platforms and through emails to get more additional information on this. Our theme for the webinar is really going to be helping to break down the barriers in maternal and pediatric therapeutics, introducing our MPRINT Hub centers, as well as some of the other networks that are involved in maternal and pediatric therapeutics research, and developing collaborations and networking amongst them. Secondly, I'd like to announce that our opportunity and support pool funding applications are now open as well. We invite you to submit a one-page letter of intent by April 30th to info@mprint.org if you are interested, and then we can provide you with additional details on the funding mechanisms. The application deadline for the full application will be May 31st, 2022, with a start date of August 1st. And these are two separate funding opportunities, or really three separate funding opportunities. The opportunity pool is managed by the IU OSU Knowledge Research and Coordinating Center, and is designed to support projects that address emergent needs and leverage novel technologies in maternal and pediatric therapeutics. We have two levels of award, $25,000 total cost for fellow awards and up to $150,000 for a faculty award. The UCSD and Vanderbilt University Medical Center Centers of Excellence in Therapeutics each have $150,000 available for their support pool funds, and these are intended to help fund innovative pilot or feasibility studies, or studies that address emerging needs or gaps in current and ongoing MPRINT projects. So these support pools typically will use one of their core labs at Vanderbilt or UCSD, or work with those centers. So again, if you're interested in additional information or have an idea that you would like to run by the committee, please email info@mprint.org for additional information. With that, we will begin our seminar in our Bioethical Roundtable today on maternal and pediatric research. Our speakers are Peter Schwartz, the director of the IU Center for Bioethics and an associate professor of medicine at Indiana University; David Haas, who is the vice chair for research and the Robert A. Nunsick Professor of Obstetrics and Gynecology at IU. Representing our pediatric side is William Kronenberger, a professor and director, section of psychology and interim co-chair for the Department of Psychiatry at Indiana University; and Bethany Johnson, who is the director for the Human Research Protection Program here at Indiana University. So with that, I will stop sharing the slides and welcome our speakers to the program today, and start with our first question. I'd also invite those in attendance, if you have questions you would like to ask our panelists, to please feel free to put them in the chat or the question and answer boxes, and we can address those as well. If you have discussion items you'd also like to discuss, we can also promote you to allow you to speak. All right. So the first question really is setting the context for our discussion today, and the fact that pregnant women and children have historically been excluded from research studies. While there's been efforts to increase participation of women in childbearing age and children in clinical studies and earlier in the drug development process, it continues to be challenging to study medications in pregnancy and during childhood. For instance, research on the COVID vaccine and treatments were limited in pregnant women and children in spite of recommendations to treat these populations. Would you be able to comment on this? David, perhaps we can start with you.
Sure. It's definitely something that has been a problem, and I would love to sort of set a little bit of the stage for why and where we got to this. So I'm going to share just 3 quick slides that highlight this a little bit. So this is the classic example that sort of highlights where we went wrong and why we got ourselves into this situation where we're at right now. Most of the people on this call probably know the story of thalidomide. It was basically meant to cure everything in pregnancy. Mice and rat studies did not see limb reduction defects. It was a sedative tranquilizer used, and actually there were ads in Germany that called it the wonder drug. And then we started getting these reports that it actually wasn't, that the mice and rat data did not translate into humans, and we got a lot of limb reduction defects. I guess I can go to the big slide. One of the things between that and alcohol, then a lot of findings started coming out, and it essentially swung the pendulum really far towards basically exclusion of pregnant women for fear of fetal effects. And it was nearly universal. And a lot of the medical legal climate in the US around that time in the late 70s, early 80s really helped push us away from including pregnant women or small children in nearly anything with fear of this exposure. One of the drugs, I love this epidemiologic study about bendectin. This is a drug that got totally swept up in this medical legal problems. Bendectin was a combination of an antihistamine and vitamin B6 that was used by a ton of women in the 70s and 80s, basically because it really helped with morning sickness. And nearly everybody got morning sickness. Well, because of recall bias, because so many people took it, it was getting linked in some studies to birth defects, even though it was never demonstrated ever in any meta-analyses or anything to lead to birth defects. And the company just got tired of fighting all of these litigations. And so they took it off the market in 1983. And in this slide, what you can see is the dark line is bendectin prescriptions, which essentially went to 0. The middle gray line is birth defects. And the open diamonds are hospitalizations for hyperemesis gravidera, or severe hyperemesis, severe morning sickness. And as you can see, these kind of things show that by not doing research and not believing what research we had, taking good, effective medications off the market harmed people. So we need to have this information. And that was when the Institute of Medicine in '94 came out with their report on women in research. NIH sort of helped push the pendulum back to the fact that we really need to get data on pregnant women. And part of the reason is because pregnant women are different and their physiology changes, drug metabolism parameters change. So we really need to get these data pretty well hammered out. And that's why I think emphasizing inclusion as opposed to exclusion and how can we make this safe is really important. I'm going to stop sharing my screen and let Dr. Cronenberger talk about PEDS if he wants to. But I think the main thing when we saw this with COVID was still this fear still permeates. We're trying as much as we can, and the PregLac initiative was great in terms of really putting some money and some emphasis behind these efforts. But I think we have to go into more of how do we make things safe while including, as opposed to the knee-jerk being, we're going to just exclude them first and make people beg for getting them into trials.
Yeah, sort of in a semi-related issue, I think a similar thing has happened with children and psychiatric medications where, certainly in the 60s, 70s, 80s, 90s, most FDA registration trials for new psychiatric medications did not include use with children. But then certain medications, particularly those for ADHD, depression, anxiety, would be prescribed fairly routinely off-label for children. And so at that point, you have a medication that's being prescribed admittedly off-label at that point, but for a population that there has not been a systematic FDA-approved trial for. And in response to this, I think it was the 90s, the FDA came out with an offer of patent extension for medications when there were clinical trials, registration trials with children. The idea being that if we are going to use these medications with children de facto off-label, we should test them. And so one example of a medication that really from the start went through that relatively early after the FDA came out with this was Strattera, atomoxetine, which was tried on children as well as adults when it went through the FDA registration trials. So I think something else to consider here with the research with children is to what extent is this research, and in this case, I think medication clinical trials is a fairly obvious example, but to what extent is this research going to be carried over into use with children in the clinical setting? And what is the responsibilities of researchers to do the evaluations, the scientific evaluations and research to support that? Bearing in mind that, of course, people want to minimize the use of medications, certainly psychiatric medications with children as much as possible, but they do show immense benefit, and these medications were being used with children.
Thanks, Bill. Those are great comments, and I learned from both of you. And by the way, thank you to Professor Quinney and the MPRINT team for having us and this opportunity to discuss some of these interesting issues. I'm going to take it a little more theoretical, actually. I think it's really fascinating how, looking back at this history and realizing how important it is to do this research and to overcome these barriers. One of the barriers has to do with the feeling of responsibility for causing harm. And so use the COVID example with either pregnant women or with children. If you put them through a research project to identify the effectiveness and the risk of a medication or a vaccine like the COVID vaccine, you're going to expose them to risk, and of course very concerning risk, and especially in the case of children and pregnant women for fetuses, given general attitudes, a lot of concerns about causing harm. But of course, if you don't do that research, as both David and William mentioned, the danger, the assuredness is that there will be treatment using these medications in these populations. And so you could see harm there. So you will see harm there, potentially much greater harm than you would have caused by doing the research study. The other option was, of course, to avoid making a vaccine or a medication available in those populations. Again, great harm. And the only reason why you even think about doing that is because of a feeling like in a research study, I caused the harm. Right, I did a research study that caused harm to these pregnant women and their fetuses, or to children. Whereas in the other options, where I make it available without testing, or I don't make it available at all, I allow harm to occur. And those, from one frame of mind, those should not be different things. People are harmed, and if fewer are harmed by doing the research, that's got to be better than more being harmed by something I didn't do, by something that was done by the disease or by a use of medicine I never approved. So it actually reminded me, as I was thinking about preparing for this panel, and I haven't really thought about this before, it's probably been talked about by others, it actually comes back to a very famous philosophical puzzle, which is actually popular and well known now, thanks to the TV show The Good Place, called the trolley problem, right? So the trolley problem is an old philosophical puzzle, which is that you're standing, here you go, I'll do it with, I don't want to take up all the time, but it's fun, I promise you. And I think it's actually a theoretical background here, which is that you're standing on a bridge and you're watching a trolley go by. It's out of control, there's no driver. Ahead of it on the track are 5 workers who do not see it coming. It's an electric trolley, I guess, or it's just out of control. They don't see it coming. They will certainly be killed by the trolley if you do nothing. There's a switch on the bridge. You're lucky. You're standing near the switch for a switch that's coming up. The trolley will come up. And if you throw the switch, the trolley will divert and go down a arm of the track where there's only 1 worker. It will certainly kill that worker if you throw the switch. And the question is, should you throw the switch? Should you cause a death of 1 person to save you had nothing to do with, to save the non-caused death of 5 people? And almost everybody being told this story will tell you that you should throw the switch. I mean, it can go back and forth. Philosophers can argue about it. If we do this with a class of students, as us philosophers like to do, because we don't have better things, it's good fun. They all want to throw the switch. Of course, I'll sacrifice. I know it's my responsibility, but I'll take the responsibility to save the 5. And they'll say things like, letting the 5 die is my responsibility too, even though I didn't do anything. If you really want to have fun, what you next do is you say, okay, same situation. Trolley out of control, you're on the bridge, but there's no switch. Out of luck, no switch. But there's a hefty fellow sitting on the edge of the bridge enjoying the sunset. And if you give him a good shove, he'll fall onto the track and he will stop the train. A big person's fault, doesn't really matter. They made it fat shaming, of course. It's an old example. But a person, you can push a person in front of the trolley, which will stop the trolley and similarly save the 5. Will you still do it? Now the class will split. Half of them will agree to push the person. Half of them will say, no, I can't push him. I could have turned the trolley, but pushing a person in front of a trolley, I can't do. It's too direct. I will not take that responsibility for killing a person just to save 5. And I think here you're seeing, right? You're switching from that thought of course you would do the research to save people future harm. Just because you might cause harm in your research doesn't mean you accept the future harm, to a situation of feeling more responsibility. By the way, the final case we tell people, and here I'll show you the slide. I actually borrowed this from one of my professors who actually had a nice slide about this. Right, so this is the first case where you can throw the switch. This is the second case where you're going to throw the person in front of the trolley. And this is the third case. This is the case where you're in a doctor's office. You're the greatest transplant surgeon in Indianapolis, like David. No, like at least he does surgery, unlike me. So you have a person who is dying, and I'm sorry, you have 5 patients who are dying. One is dying of liver failure, one of lungs, one of kidney failure, one of heart failure. And you have no organs to transplant. So these 5 people are going to die. Luckily, I'm not sure who this is supposed to be. It's supposed to be the doctor or somebody's in the waiting room. Peter Schwartz actually in for his yearly physical. He's actually pretty healthy and he's asleep. And it'd be so easy just to chloroform him and take his organs to save 5 people. Would you do that? And at that point in the class, the students all say that they would not do it. They all say, I would never cut up. I'm trying to figure out how to stop my share now, which of course I'm not able to do. There it is. What? I don't want to stop my share. Punishment to me to do this. Oh, wait, stop share. So anyway, so they say not to. So I'm going to put to you, when we think about this kind of case, we think about the damage that we will do, the moral responsibility we'll have by acting and potentially causing harm. We're going to talk a lot about different techniques to minimize that harm, to try to avoid that harm as much as possible. But we are, of course, taking a road where there can be harm in exchange for saving harm in the future, which would have occurred if we hadn't done the research correctly. And so I'd say that's actually an interesting analogy for us. And I think what's interesting about the analogy is the ways in which your mindset can shift from the thought of course, I would never do that, push a person from a trolley, do surgery to kill 1 person to save 5, versus the cases where of course we would do it, like throwing the switch to just turn the trolley. The final thing I'll say about all this is I'm being horribly long-winded, with danger of having me on the panel talking about something I don't know about. So I can talk longer when I don't know what I'm saying. But the second thing is that we're supposedly having a revolution in research now of learning healthcare systems, where we don't draw as sharp a line between doing the care and doing the research. I can say more about that later, but I think this is a great example of it. When you say this is research, we're putting these people at risk, and therefore now we're going to accept that we're going to cause harm in order to avoid future harm. I think we're going to be moving away from that as we realize ways to enmesh research into clinical care, where the act of doing important studies to understand the risks and the benefits of treatments and other things for pregnant women and for children will become more enmeshed in the provision of normal care.
Great, thank you. Beth, do you have any comments on this area?
I think they covered it. I don't have anything to add on this one.
I will ask you another question that's more related to the protection of human subjects then. One of the keys in sending a research request for a pregnancy study or a pediatric study through an IRB, specifically in the area of drugs and pharmacotherapy, is not increasing risk above minimal risk. Can you talk about how you define minimal risk, particularly, in an example potentially where there's multiple sets of maybe small risk, and can that then lead to a larger risk in an individual?
Yeah. I think the first kind of big misunderstanding about how we quantify risk at the IRB is that we don't look at the situation that the patient is in and what else might happen to them. So we don't say, this person would get this treatment, if not for the research study, but because of the research study, they're getting this, and we do not weigh those against one another. We look just at the research intervention and whether that standing on its own is considered minimal risk or greater than minimal risk. So in a drug study, it's almost always going to be greater than minimal risk, because we're not going to say, you might have gotten this antibiotic, but you'll get this antibiotic. So the risks of the two antibiotics are very similar, therefore minimal risk. Instead, we look alone at the research antibiotic and we say, what are the bad things that could happen with this? And even if it's a small magnitude of risk, if it is more than that person might experience in their daily activities or in the course of a regular routine medical intervention or exam, we consider that to be greater than minimal risk. So I know that's not a very specific answer, but it's a pretty low bar, which is, I think, the thing to know about clinical trials is they're almost always going to be greater than minimal risk because we don't do that comparison between interventions.
Can I ask Bethany why we do it that way? I mean, I guess I haven't thought about it. I could probably come up with a defense. I can defend anything, as you just saw from my previous comments. But it is a puzzling thing, right? It's like, well, you're going to get an antibiotic anyway. You're going to get one of two. The risks for the two antibiotics are similar, maybe, even though one's got, they both have significant risks or something. Why would that be that we wouldn't consider participation minimal?
That's a great question. And I don't mean to fall back on this as a default, because I think it's not just a throwaway answer, but it's the federal regulations. So much of this is defined by the rules under which we have to operate. So the IRB doesn't get to say, I think this is a good idea, or I think it isn't. They have to fit particularly this research with pregnant women and children into various categories. And we can't go beyond what those categories allow. So the federal regulations tell us what the definition of minimal risk is. The frequency and magnitude need to be similar to what's experienced in that everyday life of the individual. And there's guidance from the federal agencies that tells us that we should not be comparing that to a sick patient or a child that is receiving that treatment, that it has to be compared to somebody who is not in that situation. Should we change that? A lot of people argue we should, and I think that's part of that learning health system. And some of the arguments we're seeing coming out about that we should treat some of this research differently, maybe consider waivers of consent in these situations, where we're really just looking at comparing two different types of treatment when they would be getting a treatment anyway. There's a lot of controversy around how we classify risk on that type of research, what we call comparative effectiveness research, and how we should treat the consent process for that when they are going through a treatment setting, but there's a research component to it.
Yeah, Beth, that's a great point. I think that you highlighted something that I think is there's an appetite for changing the regulations. I mean, we still have to protect and we have to understand things, but your example is very clear, Peter. We had a situation where people getting labor induction, they're all going to get misoprostol. We were just going to give it either one way or another, but they were all going to get it anyway. But we had to file an investigation new drug application and go through 25,000 hoops to get that study done. And it's something that maybe the regulations do need some updating in those kind of clinical care settings where you're trying to do a pragmatic trial and you're trying to, instead of allow the clinical care decisions, we need to actually do the research like you were talking about. Because if you don't do the research, more people are going to be getting these things clinically just based on, the well-meaning practitioner who has read about this intervention and it's recommended even by some of the organizations. And so you're going to do it even though there's not enough data to really give clear guidance.
And I think it comes down to the IRB and the whole research enterprise is focused on protection. You don't hear people talk a lot about benefit and, the results that might come out. Of course, that's a part of research, but everybody doing the review, the FDA, the IRB, the institution, is looking at it from a protection perspective first. So we're weighing that before we think about any potential benefit either to those subjects or to future patients.
Beth, I'm going to take this 1 second because I love bragging on our IU-IRB because it is the best I have ever worked with anywhere, because you guys get it and you sort of understand and work with investigators about these, and you're very forward thinking on these projects and on these problems that come up as you're balancing these things out. So I just want to congratulate you and all the IRB staff because it's a pleasure to work with people who actually think about these things and try to think through them in a logical and rational and patient-centered way.
Thank you. I will give a quick IRB plug. We want to be partners in the research process. That is how we view our office. We want you to be compliant, but we want research to move forward. We want you to be innovative. So come talk to us. We will, Dr. Haas can attest to it probably better than anyone on campus. We will do everything possible to help your research to proceed.
I got to add my voice too, David. I'm glad you took that opportunity to give compliments where compliments are due. The IUIRB is unusual in its willingness exactly to work together with always protection still forefront, but also bringing forward the importance of actually doing the research as well in ways that protect the patients and is consistent with regulation. The reason why I'm an ethicist, I'm not a regulator, I'm an ethicist. So I don't have to worry about I do worry about it, I have to learn from it. But I don't have to just follow regulation. I'm always interested in questions about how things are interpreted. And in the case of regulation, there are many cases where things are squishy. And we're thinking through how to best protect patients and advance research. There's a place for that in applying the regulation. And at every stage, the IRB does that. And I'm going to say, I'm just been involved in a multi-site study recently where I'm dealing with another university's IRB. Many people on this call probably know what it's like. And you walk away from those experiences realizing how special it is what IU has accomplished, what you've accomplished, Beth, and your team. So it's very important.
Great. Thank you for those comments. I think now we'll switch directions a little bit, moving into that real world evidence and learning healthcare system that Dr. Schwartz alluded to previously. So, I know a lot of our programs within MPRINT and other collaborators use a lot of real world evidence, and it's increasingly used to support research that can provide valuable information for populations such as pregnant women and children who are often limited from participation in traditional studies because of these risks that may be involved. How can we utilize real-world data, for instance, from electronic health records while protecting an individual's autonomy and rights? And what requirements do we need to ensure that the data is not identifiable?
I can quickly speak to the regulatory piece here. I think we saw a really good shift in 2018 when the new common rule came out, which said that if we're using health data, HIPAA provides enough protection. We really don't need a lot of research protections on top of that. So we saw a shift in how we review these and how we regulate these to really just focus on the HIPAA components. So as long as you are protecting that information and de-identifying it as is required under HIPAA, it's pretty wide open to use medical record information for research. And I'll let everybody else speak to the practicality pieces.
I guess from a practical standpoint, it's great when you can have, electronic health records from multiple systems that are all using the same records. It would be ideal, obviously, if we had one medical record system for the whole country and every person all together, but we don't. I think the main hesitation I always have with that kind of data is it's only as good as the providers who put the data in. Using structured fields versus unstructured fields, and how do you capture, adverse effects? It's not always put in to some of the charts the way that it would be capturable in some of the real world evidence. So I think you have to be careful about that, and that's why informatics people and folks who look at these and can quantify this better are really important in the health information arena when you're looking at these kind of data. But I think in general, it's great if you can use big administrative databases, as long as they're really, if it's not garbage in equals garbage out, you've got to have the good stuff going in, and you have to train the providers to make sure that they're actually putting things in a format that can be searchable and discoverable.
Yeah, David, I'll jump in next if that's okay. Bill, do you want to go?
Yes, no.
Yeah, so think about the ethics of data and data use is that this, I was gonna say there's no bigger topic. I guess COVID's a bigger topic, but we live in the big data world, and so the idea of using data for research, those of us who live in this silo, the arena of medical research, we think about the use of data in medicine and medical research, but within a society where I thought about use and misuse and oversharing of data is on a lot of people's minds, is basically generating a tremendous amount of income for certain companies like Google, Facebook, et cetera. Sort of the great industries of our time are managing data and taking advantage of data. And of course, that's creating all kinds of controversy and problems. And of course, we get involved in data use. Regan Street has this great health information, has created the opportunity to do great research through the Indiana, IHI and these groups, and as David's saying, even more broadly with groups that are collecting data even between states. And so, how do we think about this? Is there an ethics of it? And the first ethics is we have to do it. As David's saying, there are limitations to it. But one of my favorite stories about this was a great scientist in Australia. She just discovered the link between vitamin D and sorry, I'm going to stress on folate and neural tube defects. Fiona Stanley, who was explaining to patients about how they were going to start using their data, and they said, "Why aren't you already? Like, what are you talking about? How could it be that the healthcare system is not using my data already to advance medicine?" And so that's another ethic imperative in this area, to use the data as well as we can. Now, of course, the responsibility is to also use it safely, protect people's identity, and as Beth was saying, make sure we've de-identified in ways to protect people as much as possible. We did some research with the biobank here to see whether patients understand how their data is being used after they sign up for the biobank. And it's interesting. It's interesting results we've had published. I can share the papers with anybody who wants. But patients do not understand very well how their data is being used. Some of those concerns that we see society-wide about use of data without people's understanding is actually, it applies to biobanks, both in the research we've done here and other places. People understand certain things. They understand they're involved in research by joining a biobank. They understand that research will get some information. But to understand that we're going to be accessing the electronic health record repeatedly and then sharing that data in a de-identified way with potentially researchers around the world is generally not understood well. And we asked them, why didn't you understand this? We gave you an informed consent form, which said in 6th grade language, as well as we could, maybe it was 8th grade language, what we were doing and how your data would be used, what the protections would be. And the patients said they didn't read it. They said, I trust IU Health. These were IU Health patients. I trust they wouldn't take advantage of me. And we said, no, but you don't understand. You misunderstood how it would use their data. And they said, oh, well, you know what? I didn't think they'd use my data that way, but if they do, it's fine. And so we do have a lot of now more empirical evidence, both by us and other groups, that patients actually want their data used. They don't understand well how it's being used. And when they're instructed about it, they generally often are pretty comfortable. Now that doesn't speak for everybody. Some people are very unhappy about the way their data is used and a certain ownership interest in it and say, I own my data. You just should not be touching it without my consent, my explicit consent where I actually understand exactly what you're doing. That's a great debate. That's a debate we're actually doing some research on to find out more about how people think when they understand the trade-offs involved. And I will say this, the idea of owning data, an individual owning their own data, even if it's de-identified, so you've removed or at least reduced greatly any risk of harm, is an odd idea. The idea that you own something that's happened because you were in a specific situation. So you own the data my doctor wrote down in my note. You own the data that was the result of a laboratory test your doctor ordered that you underwent. The idea of ownership here, it stresses the idea of ownership, and it actually raises about as many questions as it solves. However, it's a concept that's in this realm, and we need to address it and think about it to get this right.
Yeah, I was actually, at the risk of stating the obvious, I was going to say one, really great resource that we all have are informatics specialists and informatics processes that have been put in place for real world data. And, Peter mentioned Regenstrief, and that's my experience. It's so nice to have about as close to a plug and play as you can with people who are experts, who have worked with this, who have done other studies. I think that that's an immense asset that you should utilize whenever you can. And obviously in Regenstrief's case, you have all those people right there, but even for something like Cerner or IU Health, there are probably informatics specialists who can work with you and help you to utilize that data. I think it offers immense benefit. Several of us have talked about these kinds of studies, and so we don't want to not do them when in fact we're not actually protecting anyone if we can de-identify the data. We just want to make sure that it's done properly. And I'll raise one other interesting issue that's come up in psychology, and I don't know to what extent this has touched other fields, but when talking about these large databases and real world data, a lot of psychological tests when we have to score them. So, I may have a patient take a test for me, but in order to get those scores, it has to be sent to a central server, which is held by a test publisher, which is external to the IU Health organization. And if the patient or I have entered identifiable data, so let's say that I put their name in, their date of birth, their address, and then they complete on the computer a psychological test, and it is now sent to a test publisher, say in, I don't want to pick on any particular state. Many of them are located in New Jersey though. Anyway, that is now held in an external server, and that is a patient's information. And then those publishers will pull that data and de-identify it in use for their research and psychological tests. And this has been a concern for a lot of psychologists. To what extent do we have responsibility for informing our patients or even getting consent from them that this information is being sent to the publishers? I can tell you how I've dealt with it. Every time that I have a patient do one of these tests, I essentially put in bogus information. I can't do that for their date of birth, so that's unfortunate because I need their age. But I do not put in their correct name, and I make sure that if an address is asked for, I don't put in a correct address. And I've been clear with the publishers that I'm doing that, and they've said that's okay. But that's another thing that you need to look at the escape of identifiable data from your system into another research system where it may be used.
What I love about your example, Bill, is that it's a way of being aware of the ethics and actually acting to add protection while allowing all the research to go forward.
Building on that data ownership and consent option, one of the questions that was brought up during our real world evidence talk a couple of months ago by Sarah Van Driest was the need for potential reconsent from children who are involved in research or were involved in research as an infant, and then are, their data is continuing to be used. Is there anything any of you can provide on information on that topic, and at what point do we need to consider reconsenting children who have been involved in a longitudinal project?
Yeah, that's a great question. I love this one. So I'm excited to hear everybody's discussion on this, but it is required that you reconsent. So if somebody has participated in a research study as a minor and they age up to 18, under the regulations, you no longer have consent for their participation in that study. So if you're still interacting, if you're still collecting identifiable information, if you're still using identifiable information under the regulations, you do need consent from that now adult subject. Your other option, you say you got the sample when they were 5 years old, they have moved out of state, you have lost contact with them, you can request a waiver from the IRB. And generally that would be granted, very likely to be granted if the child provided assent and they were, say, 14 and up. That's a pretty solid decision. It doesn't count, but it indicates their willingness to participate. Perhaps less likely if it's a sensitive condition and they were particularly young and didn't have a say in that process. But those are the two options: reconsent, request a waiver from the IRB. I think it gets really interesting where you're no longer using identifiable information. So what if you have their biospecimens, that genetic information, but it's de-identified technically because we don't consider a biospecimen to be identifiable at this point in time. And I would love to hear others' thoughts on that question.
I don't know if I have a coherent thought, Beth, but the difference between continued interaction, where you need to get reconsent, of course, is clear. The idea of de-identified information, I think that's almost clearly that you shouldn't have to, although it sounds like there's some ambiguity in the written regulations, maybe in the practice. The identifiable information is really interesting. It's a really interesting gray area for me, because on the one hand, I sort of, I'm liberal about these things. I worry about harm, and I worry about, how a person's their identity is being protected, being used in a way that is most deferential and respectful of the individual. But if it really does have to be identifiable and continue to be identifiable, that's a great question. I worry that having to contact them to reconsent them is almost exposing them to more risk and burden than just continuing to use their identified data. But again, I think it's more it's a fine point. It has to come down to a question of what people are comfortable with. I don't see a clear ethical reason why we would have to reconsent a person, go back to them and ask them, can we keep using your identifiable information? But I can see both sides on this one. Like I said, not a coherent concept.
So this is also one of these that's a nightmare in actual practice. And actually one of the things that I teach folks who are doing research with kids is de-identify your data as soon as possible, because then now this is no longer an issue. It's no longer identifiable research data at that point. Theoretically, Beth, correct me if I'm wrong. I know we've been over this at IRB meetings. Full disclosure, Beth and I work together on the IRB. If you have a group of, kids that you are following, or that you've evaluated, and they are in an identifiable database, and you are doing work with that database, you would technically have to keep track of all their ages, and consent them before you did anything with the data when they turned adult. Is that correct, Beth?
You are correct. Under the regulations, that is the rule.
So yes, so as Beth knows, we get into this a lot. We are 100% behind following the regulations. I mean, absolutely. That doesn't mean that we have to sit back and say the regulation shouldn't be changed or that they aren't flawed. It's one thing to follow the regulations, and it's another thing to have a higher order of ethical thinking where you can attempt to address them at the same time. But obviously follow the regulations first. I will say though, I mean, think about what this would be in practice. What if it's 2 days after someone turns 18 and you have analyzed the data 1 day after they've turned, or it's 3 days after they've turned 18 and you pulled up the SPSS data set and looked at their identifiable information, or, you know, maybe you you ran some preliminary analyses. I mean, it becomes a nightmare to figure out how and when to implement this, but technically you're supposed to. Beth and I both serve on the IRB that handles research noncompliance, and we certainly don't want to invite, you know, a gabillion noncompliance reports. On the other hand, it's a rule that has to be followed, and I think researchers just have to be aware of it. And if possible, de-identify your data when you can.
I think another interesting thing that I honestly hadn't thought a whole lot about before, but as we look at life course kind of research, and that, you know, children's health and adult health can actually be traced back to intrauterine life and what was happening while you were in your mother's womb, and those complications could drive some of your health outcomes. You know, who owns pregnancy data? Is that, if I'm looking at 5 and 6 year olds and I want to get information from when they were pregnant, do I have to go back and consent their moms to get those data? What about specimens? Is the placenta belong to the kid, or does it belong to the mom? I mean, this gets really sticky in terms of ownership of those data. You're right, you want to de-identify it, but the more we find that all of these things really play out long term in terms of not only the woman's health, but also of the kid's health. You know, these are issues that we're going to continue to struggle with, particularly as we look at longer term data from health systems.
Yeah, I think one of the things that's coming up a lot in recent years is the idea of what people call front door consent. So you show up at the hospital for any sort of treatment as a patient, and you're consented for the use of all of your data for research purposes. It sounds great because that covers you, you know. Then from there on out, anybody can use your data for anything and they don't have to go through that process again. It becomes sticky from a regulatory perspective, though, because how do we handle the no's in those situations? Because right now, you know, what Dr. Haas described, we would grant waivers for that. We would say, you know, it's probably not practicable to track down that person in some of these situations, or every person that might be linked and involved, and get their consent. So we do waivers. However, if you implement this front door consent process, which is a potential solution, if somebody says no, does that eliminate the ability to do waivers down the road? Because now somebody has said on the record, I don't want my data used for research. So there becomes some ethical issues with then in the future granting waivers and allowing use of that data. So there's no great path forward for some of these questions.
Well, and that gets into also, you know, how much understanding is there of that consent process at the front door? Somebody's walking in with chest pain, having a heart attack, you know, they're not really in the right state of mind to sign consent and go through the process of understanding those kinds of things.
And this gets back to that learning healthcare system concept, which is, I think, an important thing to be watching over this next generation, which is that, you know, the idea of ask people consent for using their data for research. If you drill down into that, so what are we doing exactly when you're asking that? You're saying, you know, do you consent to letting your, you know, the effective treatments on you and the way your care goes influence and affect and improve the future care of patients who are going to be just like you arriving 20 years from now? Isn't there an ethical, I'm going to an obligation, you could use a weaker word maybe, to participate in a process that you are benefiting from and you're benefiting other people for? And when you ask a person that question, what exactly are you expecting them to reflect on when they answer it? How selfish are you? Is that really what you're asking? When you ask somebody, will you participate in a research project? You're asking them, will they take additional time, take on additional risks to do something which will help advance science, maybe take a medicine that hasn't been proven before? That's a very important place for consent. But this place for consent, it almost boggles the mind what exactly you're asking a person. Like, how scared and mean are you? You know, or how uninformed are you about what we can do to protect your data? And if you're going to ask that question, really, you have an obligation to make sure they understand what you're asking. Obviously, we're living in a time now where there's tremendous distrust, and you know, the cause of that distrust are complex, both societal and economic, and sure, some blame has to be placed on the medical establishment taking its liberties with people's, you know, consent in various settings. But is that something we need to build on to make a more ethical research structure, to have more cases of trying to reassure and address people's choices in situations where, like David said, you might be scared and sick, or even if you're healthy and seeing your doctor, where the question doesn't make very much sense to ask, especially if you're serving the public with the activities you're recommending.
Thanks. Great discussion, and really interesting viewpoints on this. Bill, do you have comments on it?
I was just going to say it gets even messier when you go into the world of assent with kids, because then you can take everything that Peter and David just said about consent, and you've got to filter it through the mind of a child and the interactions that you're having with the child. And so, concrete example, child comes in, they're eligible for a clinical trial for their condition. This clinical trial is, let's go to the extreme and say it's the only chance they have to get better from a catastrophic condition. The parent says, absolutely, I consent to this. And the child says, no way, I don't assent. Now, I'm sure Beth will invoke all kinds of rules and stuff that'll fix that, of course. And it's fairly routine that look, no kid goes dancing into a blood draw. Okay. So if your protocol involves a blood draw, assent or not, you can assume the child's not thrilled about it. But then there are sort of lesser things. So still serious, but what if a child has a behavioral condition that's interfering with their daily functioning, and they can participate in a clinical trial that would help them, and their parent really wants them to, and they don't assent? At what point does that assent and the extent to which the child objects become where you say no? I will say, in my experience, 99.999% of the time, if the parent consents, the child assents, and that's fine. But we're also here to consider that 0.1% that's tricky, and it's a challenging thing. How we consider that assent versus consent process.
Thank you. I think another consent issue that we struggle with is the pregnant woman and then delivering the child. And David alluded to this a little bit previously, but what role does the father have in giving consent, especially prior to delivery for an infant?
Hold up the regs on this one, because most things I know in my head, but this is a hard one. So you look at the risks to the various parties involved. You look at the risk and the benefit to the pregnant woman and the fetus. And in certain combinations, you do need the father's consent. I believe it's where there is no possibility of benefit to the woman, but the possibility of risk to the fetus. I believe that that's the combination that results in the need for the father's consent as well, but it's pretty limited. We don't see a lot of research like that. So generally the pregnant woman can consent on her own, and there's not really a formal role for the father in that process. I don't know how that plays out in real life though, when you're consenting.
And I think this is a concrete example of where you pick up the phone and you call the IRB and you seek consultation, because odds are they have seen things like that, and they have people who are expert in being able to help you figure that out. I know we talked about this before, but just to reemphasize, I think that there is a narrative out there in some places that you don't contact the IRB because you don't want to poke the bear. you poke the bear, you're going to pay for it. They're going to be, eyes on you and things like that. And I can't speak to other institutions. I can't speak to this one. You are not poking the bear. If anything, you're making the bear your friend. We don't like to be the bear, but you get the idea. It is absolutely recommended to talk to the IRB, especially in situations like this where it's very, very tricky, the nuances.
I thought you were going to go with another touching metaphor, like massaging the bear or something.
The thing we see much more commonly is pregnant minors. So when mom is 16, what do you do? That is one of the mysteries of our regulations, is that in that case, mom can consent for baby's participation because she is the legal parent of that child once it's born, but she cannot consent for her own participation. Her parents have to consent. So that is one of those regulatory things that we have to follow that makes no sense to any of us, but that is what's required by the regulations.
Yeah, and this is a prime example of places where, since these are state-based regulations about emancipation of pregnant minors, that 30 some odd states, it is an emancipating condition. Indiana, it is not. It'd be really nice to get some uniformity around this, because when you're in research networks, everybody has different regulations they have to follow regarding pregnant minors.
And then what role does the father have then as soon as the baby's born? We talked about, when the child turns 18, that then the child has to consent within that day. What about, baby data? So, are we allowed to continue to collect data on the neonate that is in the maternal record, even in some cases?
Yeah, the only piece that will trigger the need for dad's consent is where the child is going to be undergoing research procedures that do not benefit the child and are an increase over minimal risk. So if it's either minimal risk, which data collection always will be, a lot of other things can also be minimal risk, or if the research interventions the child is undergoing have the possibility to benefit that child, then just mom's consent or one parent's consent is fine. You do need both parents if it is an increase over minimal risk, but sometimes the other parent isn't available. Sometimes he is completely out of the picture, or you have no contact information, or incarcerated. There are a number of things that could happen. And in those situations, there are pathways for moving forward. That's what we're here to talk with you about.
Great.
Beth and I have had that exact conversation on multiple occasions.
All right. I think our time for today is up. I thank you to all of our panelists. It's been a very interesting and educational experience. I also invite those who are attending online to continue to follow our MPRINT Hub on LinkedIn and for additional information on upcoming webinars and events. I also posted in the chat a couple of opportunities through the FDA and NASM for additional opportunities to learn about studies in pregnancy and lactation, as well as use of real world data through some workshops that are being sponsored there. So with that, I'll thank everyone and have a good afternoon.